All right. Thanks, Justin, and thanks everyone. As said, I'm Kevin Sundquist, and we're here today to talk about the story of a claim. So first, I'm going to start off with a little bit of an introduction. My name is Kevin, Vice President of Product Management here at Capital RX. Really excited to talk about this topic today, something that I've kind of been talking about or kind of been on the fringes of for a long time. I know there might be some of you who have been in a demo that I've hosted before, and I feel like I start out every demo with the story of a claim is really supposed to be housed within our software. So really, I started my career doing prospective research at Columbia's Center for Behavior and Cardiovascular Health, really focusing on the intersection of cardiovascular health and behavioral health. There was where I really started getting introduced into the importance of pharmacy claims in our healthcare experience, trying to track if members or enrollees were taking their medications, trying to track adherence, as it is incredibly important to having positive outcomes. I then moved over to Optum Insight, where I did holistic research on medical, pharmacy, and EHR data to really understand how these products and how members who have certain indications are being used in the marketplace. I then moved over to Capital RX in 2019 to focus on analytics for our PBM clients. There, I really focused on trying to utilize and display the savings provided by our model and focusing on customer service. And over time, as we released Judi in 2021, I got really interested in the company, started expanding the products that we support and the build out. So moving over to the product team, helping really build different parts of the adjudication process, from network to formulary to building out new plan elections and clinical programs, all through reporting products, given my statistics background. So, today is not about my story, right? It's about the story of a claim. So I'm going to move on next to a bit of a quick overview or agenda, some history, and then we'll get into the meat of the presentation today. So we're going to start out with some history. Then we're going to go into what is kind of the process, starting at someone going to the doctor all the way through reporting and even maybe some prospective research. And then we're going to actually go and do a little bit of a live demo within Judi, show you some of the screens and kind of really holistically bring the story together and try and really show how we try and tell the story of a claim directly within our technology today. So on a in a dark and stormy night, back in 1960s and 70s, pharmacies were actually covering the cost of medications for enrolled members in insurance plans. So PBMs started cropping up for those pharmacies to submit repayment from the PBM. So really, they would send a member would fill a drug, and the pharmacy would try and recoup the dollars that they covered for the member, whether the member had a copay, co-insurance. And then the PBM would pay back the pharmacy, and then either whether it was self-insured or fully funded, those costs would be covered by the PBM or the employer for those members, right? And then in 1987, electronic claims processing really started around. And that's when PBMs and POS systems, so point of sale systems at the retail, mail, specialty pharmacies really started being connected to each other, so we could process these claims a lot faster than someone paying a certain amount or a pharmacy waiting for mail to be passed between the two. And then in 2006, Medicare Part D became a program as the government sponsored, right? Really expanding the benefits covered by the government. Now, in terms of the actual process of a claim going through, it's more about the benefit design, the covered members, the reporting, prescription drug events, not specifically a change in how claims systematically were adjudicated, but more of like how what happened during that adjudication process. And then we view in 2021, when Judi was launched, as one of the newest and adjudication platforms in the market today, really like trying to bring everything that happens along the story, the life cycle of a claim into one single system, from eligibility management, right? Who is in your plan? If you build a plan, when is it effective? What groups are available? If you add new employees, how do you integrate them into your system? All the way through networks, right? So what pharmacies are included? Do you have an in-house pharmacy? Through formulary, drug utilization review, and clinical edits. and benefit designs, right? So all a one-stop shop for the claims experience, not only for setting up what goes into the claim, right, and how a claim processes, but also those ancillary products like billing or rebate management, along with tools that really kind of help the cycle of claims, right, going into our modeling and underwriting tool, as well as any sort of guarantee tracking through our performance module. So I'm going to move on to our next section, but just a little bit of background of how we got to a point and what a pharmacy claim really is.
Kevin, thanks. That's a great overview and helpful background. Maybe can we get into something that I think a lot of people can relate to, just making it kind of real. My kids have been in camp, and the youngest one just got sick, so we had to go to the doctor, and then they prescribed amoxicillin. We have the card, of course, and we went to the pharmacy to pick it up. The whole point is like, what happens on the back end of that?
Yeah. No. So, first of all, I'd like to say you made the right choice, right, by going to the doctor and making sure that your son was checked out, right, to make sure that it isn't something more systematic or, luckily it's something simple like amoxicillin that they need. But a lot of the times these prescriptions start at going to the doctor, right? So you want to be going to the doctor and understanding what's wrong with your self. And a lot of the times you get prescribed a medication, right? Whether it's to treat your symptoms that you're having or actually treat the root cause of the illness, right? And not every claim obviously starts from a single doctor visit. There's lots of refills that happen. But typically there is a prescription event that happens from the doctor, whether they give you a piece of paper, which is what it was like when I was a kid, that you take to the pharmacy, then you go shopping for a little bit, and you come back and pick up your med by the time it's done, or it's electronically submitted, which is one of the most common processes today. Before we actually even get to the point of sale transaction, there are also processes that I do want to mention where the doctors can actually submit a request for pricing directly to our platform or any other platform that supports a real-time connection to understand those benefits before you even go to the pharmacy, trying to make things efficient so that the member, if they're going to get a prior authorization edit, can really understand that before they even go to the pharmacy and can start initiating that process right there, so you don't have to go back to the pharmacist, or back to the doctor after your claim is rejected. So a claim gets sent to the POS system from the provider, and then the pharmacist starts filling it out. Hey, we have this drug in stock, right? If they don't have the drug, they're not going to be able to fill it. And then they submit a request to the adjudication system. Now, Ryan Kelly, our CTO, went over the process of sending from POS to a PBM's adjudication platform. It is called a switch that does that. He kind of went over that and really got a good deep dive in one of our podcast episodes. So I would encourage anyone here to go check that out. But once a claim is actually submitted by the pharmacist, assuming that they have the medication on stock, we really start with who is this person, right? Like there are millions of members and people who have benefits in America, right? A large portion of them have Medicare benefits, a large portion have Medicaid, and then a lot of people have your traditional employer-sponsored health plan, right? And there are also those who are on the exchange. So we have to figure out who this person is, right? So based on your card, it has your member ID, right? And that member ID links to a specific plan within the adjudication software, and that plan has that member categorized into a group, which is assigned a benefit, right? So your benefit is really where we understand how a claim should or should not pay based on the attributes of that specific claim. So, assuming that we find the member, or we did find the member and they're not active, right? Which would be an automatic return of, hey, your benefits are either not active yet or have been termed, as well as maybe their benefit being termed or their group. Those I will shout out if you are someone who has twins or triplets and you name your child the same first name and last name with date of birth, you're really pushing our system, and I appreciate that. But really, the first step is about understanding who you are and what benefits you have. And from that benefit, we start on the next part of the claim processing to the network, right? So where are you getting your drug filled at, right? So network can be as simple as, hey, I'm going to this retail pharmacy. I've been going there for the rest of my life, to hey, only specific medications are allowed to be filled at certain places because they're the only ones that have them in stock, right? So pharmacy section of the claim is actually really exciting. And one of my favorite parts is like, what pharmacy can fill this medication or should fill this medication, right? If we're talking about amoxicillin, it's not something that's filled via mail. It's typically a one-time event. And you get it for like, well, I don't know, 21 pills for 7 days supply. And you fill it up at your retail pharmacy and you should have no problems, right? But some medications typically are filled via a 90-day supply, a maintenance medication for chronic illnesses or chronic illness medication as well. And really, the benefit can drive incentives for that, but it typically you could run into some roadblocks around trying to fill your medication if it is a maintenance drug or something used for chronic illnesses. So when plans are deciding how to build their benefits, these are things to keep in mind. Is that the savings there could be a lot, but also it will make the members go and fill these medications at a mail. But most members who are on these medications typically are used to that and will already be filling through a mail provider. Specialty medications also have their own hoops in terms of network that need to be bared, mainly focused on cost and access, right? So limited access medications, your Trikaftas of the world, your Humira, your Stelara, those really high cost medications are typically contracted with a specific set of specialty pharmacies so that we can control costs, but also make sure that the dispensing for the plan and for the member have the lowest possible rate, because the pharmacy contracted by your PBM is what actually decides the ingredient cost, right? And we're going to get into this a little bit, but the ingredient cost of a medication is really decided by a couple sources, right? And it's focused on contracting, right? So the PBM, in order to win more business and provide more value to the members, is incentivized to get its best mutually agreeable contracts as possible. So whether that's using cash pricing at the pharmacy, so a UNC or submitted price, national average drug acquisition cost, NADAC, which is what Capital RX uses, average wholesale price, wholesale acquisition cost, MAC list, specialty price list. So really, there are various ways in which you can contract with the pharmacy from a specialty, mail, or retail perspective to try and maximize cost. So really, that ingredient cost is the cost of the pills that are directly in the bottle. Then there are also dispensing fees, which are also part of the contract in terms of covering the cost for that pharmacy to have people actually dispense those medications, and taxes, right? So those are like the big costs, right? That really are focused on when we try and build out our contracts and get the lowest possible price for the member. Because, when we talk about whole cost, right, you might have your copay, but you could also be in a high deductible plan, right? So if a drug costs $100 versus $200, the member with a $10 copay may not feel that much, but a member with a high deductible plan will pay that $200 in potentially that first fill, assuming they haven't had any other claims towards their accumulations that year. So contracts with the pharmacies are really important, not only for understanding where they should be filling the drug, but how expensive they should or should not be. So network is really where are you getting it and should you be filling it there, really, with the guardrails around the should, covering about like 2% of our medications that are specialty, and then any sort of incentivized mail. Now, this doesn't go into the in-house situation or preferred networks where, if you're a hospital system and you have your own pharmacy, when you contract with someone like Capital RX or anyone, you can actually try and incentivize your employees to go to that hospital and get really great rates because you literally control the cost of the medications. So there are definitely different ways in which the network affects how much the claim costs and where it is filled. But in our, amoxicillin example, I'm sure someone just went to their local pharmacy or chain. So the next thing, once we've identified where the drug is being filled, is what drug, right? So are there anything associated with this drug that would potentially cause problems, right? Or cause incentivization? So typically on a formulary, you have generic medications, which are drugs that are low cost. They're created by many manufacturers, and you can kind of get many different formulations of it, driving the cost down, right? And then those drugs are typically set at a lower tier. So tiers are basically identifying what medications have or do not have rebates, as well as how we want to incentivize copays, right? So a tier 1 typically is a generic. You even have further classifications of a low cost generic, high cost generic, or preferred generic, non-preferred generic. And then you go into brands. So brands are drugs that are actually currently on patent, generally. When we talk about tiers, we're really thinking about rebates, right? So typically a formulary has an open strategy or a closed strategy. So that not only in terms of what drugs are included, in terms of, hey, all drugs are included, open as you might think, versus a lot of drugs are excluded to make sure that we're maximizing the value to the plan and to the members, right? So if you have a tier 2 medication, let's say that that's preferred brands, those might be drugs that either offer really great rebates or that also are lower cost than their alternatives, right? I mean, at some point, we're trying to find the brand medication that saves both the plan and the member money at the end of the day. And then tier 3, let's say in this example, would be our non-preferred brands that might not be as cheap as their alternatives, or they might not give as great of a rebate, which are then in a transparent model passed through to the plan. I will get into rebates a little bit towards the end of this. So there are also other key parts of the formulary that a lot of people would associate. So prior authorization, right? So creation of a prior authorization is typically to make sure that the member meets medical necessity. But these things were rolled out, we talked a little bit about the history to really like control costs, but also make sure that members were filling drugs appropriately, right? A member could have a couple medications that aren't seen by a certain physician, or not meet certain criteria, and there might be alternatives. So between prior authorization, step therapies, quantity limits, which is really just trying to control that how much of a certain medication you're able to get based on how long they're supposed to be on it, right? And then age and gender edits, there might be additional guidance from the FDA that maybe a doctor isn't aware of, or just kind of like a double check to make sure that these members are getting medication. So these types of utilization management edits are controlled by a formulary team and are meant to drive and incentivize appropriate filling for the plan and for the member. There are other types of identifiers within the formulary that are also mixed in with the benefit, like Affordable Care Act medications. A lot of people want to cover preventive medications. Capital Rex identifies those on our formulary by our clinical pharmacists that manage that, or formulary pharmacists. Shout out to Nisha Vine. And then, we have other classifications that we may want to do. I mean, I don't know, raise your hand if you've heard of, a GLP-1 or a weight loss medication, right? So identification of these medications is really important for our clinical team to provide so that plans can make informed decisions, as well as be able to have those different levers and pulleys on the benefit. So really, when we're talking about the story here, we've talked a little bit about how you find a member, you then find what pharmacy they're at, and then you find out what drug is happening for them. So now it goes down to, we understand where it's being filled and what's being filled. Now we go into the benefit. So based on what's being filled and where it's being filled, there are really important parts that are decided by the benefit. And this is really where the employers and the plans come into play, where they're deciding on what network, what are our co-pays that we're going to assign, right? Most plans, at least that I've been employed by, have typically a high deductible plan and some sort of, co-pay based plan. And that really changes what premiums you pay within there, right? So the benefit is really where you decide things like accumulators, right? So that deductible, maximum out of pocket, your co-pays, whether you have a retail co-pay that's different than a mail co-pay, as well as like changing values based on days supply. As well as that selection of formulary, your selection of network, and any sort of exclusions, as I said before, like a weight loss exclusion for certain medications or drugs identified by the formulary or by drug list, as well as any sort of incentivization programs like $0 maintenance medications at mail, right? So if you're saving a ton of money on that, you might want to pass that through to the members, and that can be a benefit election that plan sponsors can make sure that they're getting the savings while also giving the member a boon to actually incentivize them to go there. We also try and build out the different ways in which you can layer on benefits. So a classic example is oncology medications. A lot of plans will elect to turn on incentivize oncology copays, right? Or setting $0 for those and those members, just setting that up, right? And having that flexibility within a single system is really important to make it clear why a claim paid and why it paid the way that it did. Um, and not even to start on clinical programs, right? There's a plethora of these out there, right? Whether we're talking about any sort of carve outs or talking about manufacturer assistance programs, or any sort of opioid safety edits. All of those things can be housed, turned off, or configured directly within a benefit. And these are all the decisions that we at least manage via a workflow, but can be turned on or off based on the plan's decision on what they want to cover for those for their members. And it can even change by plan, right? Most of the time we have a standard formulary network selection, but there can be instances where the benefits can change drastically depending on which coverage the member is in, right? So then once the decision has been made, right, not every claim pays, right? I mean, along this, there are many instances where a claim could actually reject, whether it's the member's not enrolled, whether the member is not at the right pharmacy, whether they may even have fat fingered a quantity, right? Let's say they did 900 pills for a 90-day supply instead of 90 over 90, right? So some of these things can be resolved at point of sale, right? And some of them have to go through an escalation process. A classic example is prior authorization or plan level exclusions to make sure that we're getting it right, right? I mean, like the goal here is to make sure not only that claims are pricing quickly and accurately and we're removing barriers to care, but also having some safety, right? I mean, at some point here, the goal here is to have a great experience, and it's on us as the providers and the PBM to provide that experience by having, even if we do turn on prior authorizations, to have turnaround times that are reasonable, right? Or allow pharmacists to enter in the correct values without it taking a long time, which is something that we try to provide here at Capital RX. So that kind of is the end of the point of sale returning, right? I mean, there's always a back and forth, right? Kind of like you submit this and then there's a rejection and it's maybe something you can fix and it goes through the process again, right? And we try and tell the users, at least within a single source adjudication system, all the different rejects that it could hit, right? It would be very annoying if you get, hey, you need to fill this at a different pharmacy, and then find out when you fill the drug at that pharmacy that you need a prior authorization, right? So one thing that we try and do and that we have within our single system is the ability to identify all those different roadblocks the member is going to run into, and then make sure that we resolve them all at once, as opposed to making them jump through hoops in different sections. And
Kevin, we had real quick,
oh,
we had a good question come in. I think it's a good time to ask it, and you can address it later if you need to, or just let us know. Um, Thank you for the question, Dan. With an open benefit plan, how do you know the claim outcome was correct? In particular, when the drug isn't listed on the formulary, or the formulary documentation says something like, X drug may not be covered if your plan does not include coverage of certain categories.
so if a drug is not on the formulary, right, we typically will return an MR reject saying, hey, this medication is not included. And that can actually be something that within Judi and other systems can be overridden, right? A lot of the times when setting up a formulary, those drugs are not actually included because they're potentially old or stale NDCs, right? That have been inactive via Metaspan or FDB for, a couple of years. I think the max for Metaspan is 4, and we use here at Kepler X a 2-year inactive continuous phase. So typically those are why those drugs are not included. I hope that kind of answers the question, and it's something that can be overridden, and typically we'll go through review to understand why. Whether you call our call center, right? I've actually taken calls from the call center, and being able to go into the system, see the claim that was submitted, document it, and then potentially override it and see that claim resolve on the phone with the pharmacist, something that we've done. But when setting up like an open strategy, whether it's open or it's closed, there is kind of a difference between not on the formulary versus excluded for cost savings or things along those lines, which are kind of different workflows and how they get resolved by our customer care team, or our operations manager, or our VPs of product.
Cool. Thank you.
That's a great question. Come back if you have any further.
Will do.
So, when talking about the claims, this is really where I used to only live, right? I used to only live in the, hey, the claim's been filled or the claim's been rejected. What are we reporting on, right? We all know that sometimes prescriptions aren't picked up. Maybe we forget, maybe the doctor sends it in and we don't really want to get it, or, God forbid, it's some sort of cost prohibitive reason why we wouldn't pick up our medications. But when going through this process, there are other things that happen. A claim never gets picked up, right? So then the pharmacy actually will send us back a request to reverse the claim so that we don't, erroneously pay them for something, or they, aren't on the hook for that cost for the medication that was then put back. We then have to bill the pharmacy, and we have to build the plan, right? So the pharmacy sends us a bill, or we send a payment to the pharmacy for the amount that was covered at point of sale based on the claims data that gets stored in our system, as well as then if it's a self-funded instance, which is where the employer actually covers the cost of the medication plus a potential admin fee, the claims are then sent to the plan saying, hey, here's your invoice, typically on a 2-week cycle. And then they pay us back through classic invoice systems. Then those claims are also aggregated every quarter and submitted to a rebate aggregator, or if you're a PBM that has your own, you do them yourself, right? And those go out to say, hey, this drug is or is not rebatable, and those dollars are then returned. And this is all based off of the claims data, and really is, I keep saying the story of a claim, because it does not happen after the claim is paid or rejected, right? We keep using those claims to make sure that it ends about potentially 6 months later, when that rebate is then passed back for potential, preferred brand medications or brand medications on an open formulary. And then if you are government plan, right? I mean, I know I kind of said at the beginning that government claims adjudicate differently. They do adjudicate quite a bit differently, right? And they also report differently. So to get payment, we need to submit prescription drug events, or PDEs, to the government, and you have 6 months after the close of the year to get all of your claims as either accepted, rejected, or informational, as well as encounter reporting, which is part of Medicaid. And part of that actually is the reverse and reprocess section. So a claim could pay at a certain rate, and then a member changes their eligibility, or they become low income cost subsidy eligible. So we have to reverse and reprocess that claim, and potentially even submit a member underpayment and send back a member of payment there. So those claims are even being processed internally to understand how they should have paid based on retroactive changes, right? So that doesn't even involve the point of sale. That involves an adjudication system itself taking the facts about the claim, reversing that, and then rerunning it again based on the dates of service and updated information. And then it potentially could be used for research, right? So when we're looking at plans and trying to understand cost opportunities and savings, or what are the trends based on either a specific client or a book of business, we use that claims data to make sure that that plan understands where they are and where they're going. So it could be as simple as that, or pulling a report for our clients. Most of our clients get reports sent to them, potentially even daily or almost live, right? So they can have a copy of the claims data to try and intervene, or send over to care managers to intervene on members who potentially have chronic medications. So the claim data is not just about the story of the claim does not end when it's paid or rejected, or prior authorization is submitted. It really has quite a long tail. And can be, in the system or being used by different individuals for a long time. So yeah, that's kind of our high level overview. I don't know, Justin, if there are any questions, but I was going to go into how our enterprise solution software tries to talk to our coordinators and customer success team using some of our features today.
No, I think it's a great time to do that. There's no open questions right now, and we addressed that Judi is short for adjudication, so you can go right into it from here.
Yeah, no, I mean, I think is kind of a funny slide, but really what we've been trying to say today is if you had to ask an adjudication system, like what do you do all day, right? Like, what is your job? These are some of the key words, right, that come up for us, right? And we view technology in our adjudication system as a way to make things more efficient and to increase transparency for our plans and our clients and our members, right? So what we're going to show you within Judi today is just a little bit of an example or a sample of how our teams use our tools every day, and kind of talk about the dashboard, and then we'll go into some questions. All right. Can everybody see my screen?
Yes, we can.
We're good. All right, great. That is the riskiest transition of this entire webinar. So we're doing great here. So this is the landing page of Judi. you can see that we have a modular environment. I am an administrator as the VP product, so I can see all the different parts about the story of a claim, right? So you get from the members to members module where we manage a member's eligibility, what plan they're on, to our network module where we build and manage our contracts that are then built into networks. Our formularies module where we load and manage formularies, through plan management where we do make those elections like copays. There are quite a breadth of different features that we have in here, from core adjudication, operations, financial, clinical, reporting, right? Kind of solving all those different things and having one ecosystem to do all that, ecosystem and software environment that does all the things associated with the story of a claim. I'm going to keep saying it, right? I think that that's, fair. So we're going to start in the members module, right? Where most people might think that we would start in this type of situation. So our CEO AJ is a huge, huge comic book fan. So I did have to pick one of my favorite individuals, which is Peter Parker. And we're going to search for him. Typically, when talking about a specific member or an investigation and what you would do within the system, it starts either with a claim or a member, right? And someone calls in and says, hey, I want to know what's going on with this claim. I don't know why it's rejecting or why it's paying, or hey, I'm going to fill this medication. Can you give me some more information, or what pharmacy I should go to? So this is our one-stop shop for member information. This is the landing page with your eligibility. So who is this person? Where do they live? This is actually Peter Parker's address. If anyone is interested, he's enrolled in our Daily Bugle Gold plan. He's a great photographer. That's his only job, I think, at this point in time. But these do have hot links at the top. So if you want to go to the client information, if you want to go to his specific benefit, if you want to go to their group, you can go directly there without having to go back to the main page and navigate, right? So if you had to go to another system that had benefits in another place, you would have to have multiple tabs open, right? I mean, I try not to have too many tabs open at any one time, right? And then on the left here, you can see different navigation points from, do they have any dependents? What are their claims history? What has happened, right? We have member versions to understand what's this member's history, right? Like, was their eligibility updated? Where are they in their accumulations? Have any overrides been placed for this member? Do they have any prior authorizations that have been entered? What is their in-network? So really trying to have a one-stop shop for all things that could happen when servicing a member, either over the phone or via, a request from the plan. I'm going to go into our claim screen here. And within here, you have a breadth of different filters that you can use to find the specific claim that you're interested in. And I'm going to kind of talk about how Judi tells the user the story of a claim. So I'm going to go to a paid claim. Now, this is not your son, Justin. This is a different individual here, where Judi takes all the information that happened along this claims story and puts it into real text so that someone can actually read it out in a webinar and try and tell you what happened to this claim without having to go and search for, all right, where's the copay field? Where's the NDC field? All of that information. So this claim had these different specific networks that could be checked. It hit our Capital RX big chain network and our Safeway contract. We call those agreements, which is a retail 30 type network. So this claim that had a this NDC, which had a first of pricing. So Capital RX, our clearinghouse model or single ledger model, has a first of NADAC with AWP wrap. So this claim has a NADAC price, national average drug acquisition cost, of that 73 cents. So that is the cost of the pills in this claim. So when we think about the ingredient cost, it's really driven by the quantity, right? So I will tell you that this drug was filled for a 7-day supply with 21 pills. That is the standard for amoxicillin. So that's 3 a day, if you want to do the math for me here. And then it decided that this agreement has a $4 dispensing fee. So again, that's the cost of the dispensing by the pharmacist. And these fees can range depending on whatever contract you have signed. A lot of different pricing sources potentially could have different amounts. So for example, a cash price, right? A cash price is a single dollar. You call it usual and customary, or submitted cost. Typically, those don't have a dispensing fee because that's literally what it would cost, right? When you buy something over the counter or you buy something somewhere, you don't have an ingredient cost and a dispensing fee. It's just one price, right? So it's kind of built into that price. So then based on the benefit, this member, if they were in their copay phase, would have a 10% cost share with a maximum of $10 for claims that are filled with a 7-day supply at tier 1 at a retail pharmacy, right? So that goes back to the different types of pharmacies that they're filling at. Safeway in this example is the local pharmacy that Peter Parker is filling at. Then cost share, right? So, someone's like, okay, it's a 10% copay, but how much did they actually pay, right? Because 10% of a certain amount, like how do you do that calculation? So really it just reads out for you. The cost share was the $4 dispensing fee plus the 73 cents. This member is in a deductible plan. So the member is actually going to pay this dollar amount of the full cost of the claim. Now, if they had met their accumulations, if they had had some sort of override, or if this was a drug that bypassed the deductible, they would go in and they would have paid that, I don't know, 47 cents for this medication, which would be their 10% copay. And that's kind of the story here, right? That it's filled at this pharmacy, it priced this way for this member, and this is what ended up the cost being based on their benefit, right? And this is not how all claims pay, right? Or this is our reasons for adjudication versus reasons for rejection. Now, I don't know if any of you have seen the different versions of Spider-Man, but they all involve some sort of Spider-Man being, Peter Parker being bit by a spider. Now, if anyone has been bitten by a spider, cortisone or something along those lines is something that you might want to fill. And, some plans do offer over-the-counter products through their pharmacy benefit, right? Something to think about, something that if you have members who are filling these types of things, you can actually do. Now, back to the question earlier about it, it kind of set me up for this, is some drugs are just not covered by the formulary, right? And this over-the-counter medication is not covered by the benefit because you can buy it over the counter, typically because, those are not included in the benefit because they aren't actually dispensed or typically prescribed by a doctor, or they are prescribed, but they're not actually sent via the POS system. But plans can do however they want, right? Within Judi, we have the flexibility to turn on or off these different types of things, as well as write overrides, right? So if we actually go back to the claims screen, we could actually write an override for the specific claim and run a test on it and make sure that it works, right? So these are the types of things that drive efficiency within our platform and allow our customer care reps or our plan management team to actually solve these problems. And it's live, right? I mean, I've been on the phone writing overrides and the claim will come directly in and they'll be like, hey, it's paid. And it's like, yes, I can see it as well, right? So, they aren't being written in some other system and then you have to wait for the sync, right? They're right there directly in the system for our users. So within here today, I mean, we can talk about the different benefits or, how we design those. And I'm going to pull up one here. It's in a new tab. So as I was saying before, right, the benefit is where you select all the different things associated with the claim, right? So we find a member, they're associated with this specific benefit. I'm going to flash a couple screens here just to kind of show how easy it is to turn on or off these types of elections. So network here, I filled out just a retail network for this very basic plan. You also have the ability to set up copays within here, copays and co-insurances with different levels, accumulations within our screen here. So we can see that this member has $500 deductible with $1,000 for a family type plan. Now, Peter Parker is a individual, at least in this scenario. Maybe Mary Jane and him get married later on and they'll have their family plan, as well as the ability to put in any sort of restrictions on this, right? Maybe it's combined with medical, right? I mean, a lot of times we get different types of transactions or balances from a medical vendor telling us how much they spent on the other side so that a member isn't needlessly paying for medications when they've already met their accumulations in other situations or from their medical spend. We also support category deductibles, max amount of pockets as well as category max amount of pockets. And then a breadth of different elections and exclusions from Affordable Care Act to general categories to special categories like over-the-counter medications. I do want to go back to Peter though and talk about his accumulation status. So we saw in the last claim that Peter had paid $4.73. And when we go into our screen here, one of the really great parts about this integration is that we saw that his deductible was $500, right? So within here, we don't even have to go to the benefit, right, to figure that out. And not only do we not have to go to the benefit, we can also figure out where he is if a member potentially has like 20 claims, 30 claims, 100 claims, right? And not only can you see where they are currently, you can also backdate and figure out where they were in certain claim situations if the reasons for adjudication weren't enough for you. So I want to make sure, Justin, that we're okay on time, but I think we're going to leave a couple minutes at the end for questions. But yeah, that was our high level kind of like story of a claim throughout Judi, and I hope everybody appreciated it and kind of could tie together what our discussion as well as our description and very micro demo here today.
Yeah, I was not going to stop you because you were just rolling. So we'll let you go right up until the end here. I don't see any questions currently.
Oh,
If people want to stick around for a minute, lob another question or two in, and we can absolutely address them. Happy to, or we can follow up afterward as well.
right.
Kevin, what would you say as far as the actual kind of story arc of the claim is the most unique or interesting thing about having everything in one system? Is it the ability to see and communicate the reasons why it processed effectively, or is there something else that stands out to you while we're waiting here?
Yeah, I mean, I personally think that the benefit design is probably one of the most like interesting parts, especially for testing, right? One thing that we don't talk about in the actual adjudication of claim is testing, right? Testing is incredibly important to Capital RX and to most PBMs, right? And the ability to have a single system where there's one environment where you can run test claims within a single place and make those changes and understand how the benefits are working and rerun whether a single test claim or a set of scenarios of tests is something that I find incredibly valuable. And to be honest, I use almost every day, whether it's from a single. And that was actually something I was thinking about if we wanted to going in and testing. We could do that if anyone is also interested in testing and passionate about it like me. But in terms of having a single place, like there is no disconnect, right? Like there is no way where I'm saying, well, I'm waiting on my network to be loaded and I'm waiting on my formulary to be loaded or changed. I'm waiting for an override to be synced from this other system. It's all there, right? And
That's
not
awesome.
only can we make sure that it's working, we can also test it and future date it to make sure that changes and benefit elections are processing appropriately. Then we can audit it and send it out to our clients who are interested. I don't know if any of our clients are in the audience, but we send plethora of test beds out to confirm that their benefits are adjudicating as requested.
Cool. We did have a few questions coming in here, so thank you for these. We'll run through them right now. With all the different checks a claim has to go through, how do you decide the order in which they're passed?
Yeah, no, that's a great question. So I know that it may have seemed a little bit waterfall-ish, right? In terms of like you go through this and this and this, but really what we try and do is make sure that the claims that set the next set up work out at the same time. So there are only a few things that require. So eligibility always goes first because if you don't know who a member is, you have no idea if the pharmacy is appropriate, if the drug is appropriate, if they have any benefits, right? So that's kind of the first, who is this person, right? And then from there, the pharmacy is important to get pricing, which could trigger other types of rejects, right? Like a high cost reject. So typically we talk about eligibility first to identify the member, then
Mm,
pharmacy, and then those formulary and those benefit edits kind of happen at the same time, right? Because they aren't going to block each other and aren't as much dependent. Now, identification of attributes on the formulary for copay assignment, but like when we're talking about a reject potential or an edit, right? Like that's more focused on making sure that the claim should pay. So there's just a few blockers that make sure that we cover everything before we really start doing it all at once. I hope that that kind of covers the question, but really focusing on eligibility and network
I
first.
think so. And another one, if claim adjudicates with a prior authorization, is the breakdown of the PA rolled into the other categories on the claim readout, or will there be a separate readout for PAs that were hit?
No, that's a great question. So when a claim rejects for prior authorization, or if it pays and it had an authorization, those are both tracked within the UI. We could actually pull one up if we have time at the end here. But basically, when you run a claim in the system, it will say, hey, this drug requires a prior authorization. And it will tell you that in the reasons for rejection that we kind of saw in that cortisone claim, that was an OTC. Now, prior authorization is another great example of a reason why a claim would reject. And having tools like what we call tags and override that are allow users to set up things like gold carding or other sort of like reduction to access to medication programs allows us to bypass those almost like silently, but also having an integrated prior authorization system where you can actually look up that member in the prior authorization tool and see that live claim and start a case directly from that are the types of things that, you know, we try and drive efficiency there. But is that kind of the full question there, or was there another part?
Just I think you got it. Let
I
me just
can't see the text of it, so I
let me
have to
see.
remember it from the first time.
Testing your memory. No, I think you got it. That's good.
Yeah,
Thank
just
you.
follow up in the chat if you have a question.
Yep. Yep. Uh, how does the rebate aggregator know when a claim gets rejected? Or I'm sorry, reversed?
Yeah, so that's on our team, and that's why it's actually something that I used to work on a lot, and I've worked on is that since there is kind of a lag of when you submit those, if you actually look at the data in terms of reversals, we only submit net paid claims, so that we're only going to submit what ended up being paid. Now, if you look at the tail of claims that end up getting reversed, it's a really cool chart where after about like 6 weeks, 99.95% of claims don't end up getting reversed, right? So it's kind of like if you have a quarter by quarter reporting, it's very unlikely that there will be post reversals. But to that point, we also do have the ability to, you know, send out, in my opinion, those reversals for claims that we got a rebate for. But typically, that's why we have some of these longer tails in reporting. I think actually the first time you support, it's actually 6 months to specifically avoid that. So then when you're reporting quarter by quarter, it's actually 2 months behind. So really the only claims that are eligible for that situation are claims that potentially have, you know, paid in a certain period of time. But
Okay.
yeah, it's a great question. But we do try to avoid that. And it's something that, you know, the claim lag per se is something that you want to pay attention to. You can also just use submission date on those as well.
Makes sense. During the adjudication process, you expect a certain percentage of script claims to be kicked back for repricing, et cetera.
Back for repricing. So are you talking about like alternatives? Or are you talking about like changing the pricing, or it's rejecting because they need a different like price or quantity?
Bill, if you want to layer onto that, feel free. It looks like it's specific to price point. Yep, there you go. It's price point.
Yeah, so typically when a claim comes in and it's an acceptable price, right? We don't like go out and like bid for other prices currently, but there are abilities to do that. But when a claim comes in and prices at a certain way for a member, if the member is upset about how the claim is priced, they can call in and try and get an override or play an admin level, say, hey, this drug costs a certain amount. But like in terms of point of sale repricing, yeah, sometimes they submit a reversal because the member's like, I don't want to pay for that. They can call in and sometimes it's you know, a lot of times a valid reason, right? Like they just went to the doctor, they just paid a large bill for their medical insurance and they don't think that they should have to pay it because they have met their accumulations. So then they can get an override in Judi and you know they're live immediately, right? You can get an override to allow the claim to pay at a different price. So in terms of like kicking back in terms of percentages, I wouldn't say it's that as much as it is we're doing that bidding of pricing, sometimes first of or sometimes lesser of during the adjudication process, comparing, you know, submitted usual and customary price, NADAC, or potentially any sort of specialty list, accounting for dispensing fees and ingredient costs. I hope I'm answering your question there, but you know,
I
happy to
think so.
dig in
No,
further.
we have two more for everybody that's left hanging on with us, and there's a lot of you, so thank you for that.
There's like 100 people here. It's pretty
Still,
exciting.
yeah, it's great. Um, And so just one quick thing, that's sort of all of a lot of the stuff, and you alluded to this earlier when you answered the question, but it's like that sounds like one of those things that's happening in real time, like milliseconds, where we're kind of running these processes to ensure that the claims being processed at the correct price point,
Yeah, I
right?
mean, I think our call answer times are, less than a couple seconds here these days. So,
Mm.
those are the types of things that if you can get those escalated pretty quickly, and our team is fantastic, right? Like,
Yeah.
we've really worked really hard on getting them to be able to understand how to, escalate these things and understand them and, resolve without having to escalate to someone like me because the technology is so simple.
Next one, how are changes to clients' plan benefit requirements managed in Judi, especially if they change during the plan year?
Yeah, no, that's a really great question. I hit on this a little bit earlier, but not only do we have the ability to copy a benefit, right? So if we were to go to Peter Parker's benefit, you can actually copy the existing benefit and make it active in the future. We also have something called draft benefits, so that you can actually make a draft of that benefit and you can actually run test claims against it, identifying that you want to run it against the draft, and then it will run on those changes and then you can publish them, right? So we have a couple ways that we attack that. And for us, the copy feature and the draft feature allows us to not have to basically rebuild from scratch, but also just, on a case by case basis, be able to change, if you're feeling really good about your spend this year and you want to bring down the copay to $0 for generics preemptively to the 1 year, we can do that. And then we also have within account management are bulk actions, right? So this is the ability to identify and make major changes across plans. So some of our health plan clients or some of our clients that have a breadth of different benefits, they potentially could have 100 different benefits that they want to change, right? And maybe they want to change one thing. They want to turn on a program, turn off a certain program, add a type of copay, increase something, right? These one-off changes could take a long time if you're doing them one by one. So we leverage our bulk actions to maximize that ability and be able to say, hey, for these 100 benefits, I want to copy them effective this date, right? Which will then term the existing benefits on that date. Let's say it's for 7/1 or for 9/1, right? And it will make the change and it will be live in production as soon as you process the file. So you actually get a test result and you can say, hey, I like this. This looks good. This looks good. This looks good. And then click run in production and it will push those changes to the system holistically so that you can actually make sure that your benefits are changed without having to do hours of manual UI work, as well as them being able to run test claims across all of those, right? With them being able to
Nice.
be future effective dated.
Got it. And then where is the claim processing happening for both POS or test claim is the question.
So it's a great question. So for so when you're talking about POS, it's sending us basically an electronic file that says, hey, here are all the facts about the claim, including member information, the pharmacy information, the drug, right? It could be a very small amount, it could be a large amount, right? Whether it's a primary transaction, a secondary transaction, they send us all that information. And within our adjudication platform, it basically takes that and adjudicates the claim as I described. Now, our test adjudication UI, a user actually has the ability to put in those key pieces of information like date of service, find your patient, right? Find your pharmacy and find your drug to make sure that you can actually run the claims and manage the experience. Now, when we went back to that page, if you click plus claim on one of these specifics, so we go back to Peter, it will actually fill in all the information about that claim in our test claim UI so that you don't have to really start from scratch, right? You can go directly to our test claim UI and see how that member's experience changed if you were to enact some sort of override or authorization, right? But just to, the test adjudication is actually the same adjudication process as our, general adjudication. So they mirror each other so we can get as close to experience. It's just not written to the system, right? So we actually run these claims, but we don't save them to the member record, obviously, because we don't want tests doing anything, right? For those members, right? And actually our direct member reimbursement module where you take those paper claims and you load them into the system is actually just a beefed up version of this single test claim UI where you can actually submit the claims and write them to the system right there.
Yeah. And then the question, and the guest that asked this one, if you want to clarify while I'm asking it or while Kevin's trying to answer it, please feel free. I think you're still on. So how do you decide the spread of the claim? Is it fixed or variable? And I'm not sure if you're referring to price because we're referencing a specific price, which is unique, right, Kevin?
Well, I think the question is mainly like how do we manage spread? And Capital RX today does not manage spread, which typically, and to start basics, as I know if you're asking about it, you know what it is.
Yeah,
But right, spread is where you take a claim, the pharmacy says this is how much it is based on your contract, and then you increase the ingredient cost or potentially decrease the ingredient cost or the dispensing fee amount on potentially only once or potentially twice, and then you parse out those different dollars. So a drug that costs $10 could actually be charged $11 to the plan, and then the increase there. So we, currently don't have any live, but typically when doing spread pricing, there's three methods. You can have a flat dollar amount for certain medications that serve at pharmacies. You can do a increase in percentage for certain medications and certain pharmacies, or you can have a list of medications in terms of how much you want to increase by dollar percentage amount that's loaded in for specific pharmacies, right? So, kind of different ways in which you can manage spread, across the industry. And I'm not an expert in that to be honest. But yeah, that's how you can manage it in a typical arrangement. So I will say if anyone is interested in identifying it, you need to make sure that you're getting the ingredient cost paid to the pharmacy because that's actually how much is paid versus the ingredient cost charged to the plan. Those two potentially are where you could see a difference of what was spread.
makes sense. All right. How is FWA, fraud, waste, and abuse, reviewed or factored, built into the system, or is that done via clinical edits themselves?
I think it's a all the above, right? I think that rigorous review of claims within classes at the plan level and across the book is very important to that. Because if you have a medication that doesn't have a DUR edit, I mean, there are many people that could run a claim or pharmacists that could run a claim and find out there is no edit. And, I don't think that, I'm not going to assume that anyone would do anything, but there are people that can game the system. So as much as you try and be safe, if you get a claim to pay once, you potentially could do it again. But I do think things like refill too soon, which is incredibly important to decreasing the number of claims filled and controlling that in terms of how claims are dispensed is very important. Not only because even if it's not fraud, right? If you have a claim that's dispensed like with, I don't know, even if you have 70% of the claim has to be utilized before the refill is triggered, you potentially could have a large amount of claims on hand at the end of the year. I think the current calculation with the 70 is like 3 extra fills by the end of the year. So you're paying for 3 extra claims, and that could be a lot of money, right? And at that point, the member, if it's especially if it's expensive, could have already met their accumulation, so they don't even know
Yeah.
that they're paying more money for that. So I think a combination of reporting, a great analyst on our team, as well as having different monitoring alerts within. We use AWS, so we have different events that can be triggered. We do have an entire reporting suite of claims that meet certain criteria called output and reporting, as well as those classic benefit edits to protect against that. We also have a
Fantastic.
fantastic compliance manager or head of compliance.
Heidi will appreciate that. So, and last one, what's the average response time for claim processing?
Milliseconds. I mean, like when I was writing these claims earlier today, we're talking about a couple seconds. I do think to be honest, every system has different high times and low times, right? But most of the time we're talking about milliseconds here. Kind of back to my point, when you're on the phone with the pharmacist, you can see them submitting it and see it show up in the member's profile directly.
Well, that'll do it.
Yeah, I mean, I could go into that, but yeah.
We're right at that. We're right. We just crossed the top of the
All
hour.
right, all right, all right.
People are still hanging with
Don't keep
us.
me
I gotta
talking
cut you
all
off.
day. All
I
right.
gotta cut you off. I gotta cut you off.
Okay. All right. Well, I really appreciate everyone for joining today. I can pretend to hear you all talking about what a great time this was, and I really appreciate everyone coming.
Yeah, I'll echo that, and thank you all very much from the team at Capital RX. We're glad you tuned in for this and stayed the whole time. So, thanks, and have a great rest of your day.